All right, good morning everyone. So welcome to this webinar this morning hosted by the Centre of Research Excellence in Treatable Trades. So today we're fortunate enough to be joined again by Professor James Hull, who's going to present on the bedside, the podium, physical activity and the pulmonary limiting factors. But first I'd like to start with just an acknowledgement of country, so acknowledging the Aboriginal and Torres Strait Islander peoples as the first Australian and traditional custodians of the land and the country throughout Australia, so wherever you'll be joining us from today. So for us at HMRI, we acknowledge and respect the Awabakal and the Warramai people as the traditional custodians of this land. So I'd also like to pay respects to elders, past, present, and emerging, and pay respects to any Aboriginal or Torres Strait Islander people that might be joining us here today, either in person or we have people online as well. So getting started, so we have Professor James Hull, who's a consultant respiratory physician and the lead for the unexplained breathlessness service at the Royal Brompton Hospital in London. He has a special interest in the assessment of respiratory issues in athletic individuals and in its advisor for the British Olympic team, and an honorary professor at the Institute of Sport, Exercise and Health at UCL London. So I'd like to welcome Professor Hull up. Talk about bedside to podium, physical activity and the pulmonary limiting factors.
Well, thanks very much indeed, Hayley, for that invitation. Thank you for the invitation to be here. It's fantastic to be here in Newcastle. And my challenge for this webinar is to try and address some of these issues and share some of my experience assessing physical activity and trying to understand the interplay with the respiratory system and disease which can limit performance. You heard this yesterday, but as me as a background, I work at Brompton, familiar to many of you who work with respiratory colleagues. This is South West London. And as I shared with you yesterday, I took this photo just outside my office about 5 days before I travelled to Australia, just to emphasise that it isn't always dark and rainy and wet in the UK. At Brompton, I run a service that addresses unexplained breathlessness. And essentially, we are interested in understanding why it is that people struggle with activities of daily living, and how it is that the pulmonary system might be limited and causing problems such as breathlessness, particularly when people do daily activities. For a part of my week, I also work at the Institute of Sport, Exercise and Health in Central London and try and help the UK Sports Institute, Team GB. And that's a very different challenge, in that I'm looking at individuals who are trying to perform at the very top level, win Olympic medals, compete in professional sport. And again, they have a question about why it might be that they're struggling with their performance, or they may be respiratory symptoms which are limiting them. Two ends of the spectrum in many ways, but over the course of this talk, I'm going to share some common themes that I think are useful in both ways in terms of assessing this issue. My interest in exercise started back in the 1990s with my undergraduate degree, where I was supervised by Professor Brian Witt, who was a sort of forefather of cardiopulmonary exercise testing and worked with someone called FACSM. And one of the first lectures I went to medical school, he presented this talk, and this was a sort of quote that he started with, which was that the condition of exercise is not a mere variant of the condition of rest, but it's the essence of the machine. And I have to say, at that moment, I was sort of converted into being fascinated with exercise physiology. And then as a career has developed, trying to see how pulmonary physiology fits alongside exercise performance. I'm very much interested in that as a career area. And when we think about exercise, of course, there are different limiting factors for different people. So some people might find it very difficult just to walk up a flight of stairs. And other people, of course, are trying to break marathon world records. And at the same time, people are saying, well, what are the factors that are limiting performance? And what can we do about it in our sphere of influence to try and help people perform better on a day-to-day basis? So I'm going to give away the punchline now, because you're obviously thinking, is there something that holds people back from a pulmonary perspective? Are there things that we can do to try and help people run faster? And I think as is evidence for the last sort of 5 to 10 years of the introduction of these brand new shoes, where you have a thick foam sole and a carbon inlay within them to return energy to the runner, there's a huge improvement in running performance time. Somewhere between 2 and 4% of improvement in terms of the overall performance time. Some of you may have some of these shoes, and I can't see any today. They're expensive, but they certainly make you run quicker. And instantly you can realise that if you can run quicker with a new set of shoes on, perhaps it isn't the pulmonary system which is necessarily limiting your performance. the factor which is the limiting issue. Some people wear these in the supermarket. I don't know, they break up, you lean forward and pick up your bag of carrots quicker. Of course, that doesn't necessarily stop us from being bombarded with other types of ways to improve our performance with a focus on the respiratory system. And so I don't know about you, but if you start looking at this sort of stuff on Google, then your Instagram feed or your Twitter feed will start to be presenting you with different devices or ways to try and improve your respiratory performance. So devices which can improve respiratory muscle strength, athletes telling you how they've transformed their performance using these types of devices. And then other slightly more wacky things where people breathe in oxygen through little canisters to try and give them an extra boost in the oxygen that's going around the bloodstream. Now, I always have to be a bit careful what I say about this, especially in a recorded format. I don't want to open myself up to sort of legal challenge. But if you're interested in reading a good review or following someone who actually is, scrutinises the data in this area, I'd recommend following Nick Tiller, who has a whole sort of interest in scrutinising the science behind some of these different approaches. And it's entitled Navigating Pseudoscience, which I think probably sums up some of the data. If you're interested in a sort of more legitimate and substantial scientific approach to the literature in this area, then you can go no further and read the work by Jerome Dennis. Jerome will be familiar to many of you in the audience. He's the ex-editor of the Journal of Biophysiology, and really is a powerhouse of respiratory physiology. And for the last 50 years, he spent time publishing various articles looking at describing whether the pulmonary system could be considered to be overall built or underbuilt for respiratory, for exercise performance. A number of these papers are fascinating to read. And in fact, I was lucky enough in and around the start of the pandemic to contribute with him and Andrea Gersh, who's based in Australia, as some of you know, to an article where we tried to summarise where we were in terms of the understanding of the science in the area of whether the pulmonary system limits performance. And these two are sort of powerhouses of the field, and I was there really just to try and contribute from an airway perspective to talk about some of the things I'm going to talk about today, how the airways might influence pulmonary limitation. So if I just take a step back and just go back to my days at the BSc, when I was looking at cardiopulmonary exercise testing to try and understand what limits people when they perform physical activity. And these are the so-called Wassermann cogs that most people understand when they're taught about physiology. And essentially you have someone who's performing exercise, the muscle requires oxygen, there is a waste product produced, and then there's this chain of physiological command which enables us to deliver the oxygen from the atmosphere via a pulmonary gas exchange system, cardiovascular system, which then allows us to deliver oxygen to the working muscle. And of course, the demand goes up the harder you work. And this cog diagram, you'll see reproduced in multiple different texts and publications, and it's the principle of teaching certainly medical students how to try and understand where there may be a breakdown in the line of communication that allows people to perform vigorous exercise. The big thing that is missed on these cog diagrams, for me, is this little organ, which is thought to have a peripheral role when you talk to exercise physiologists, but I think more and more we recognise that it actually plays a key role in why many, certainly our patients, will stop exercising and feel there is a pulmonary limitation, because actually there's something that's telling them the system should shut down or slow down. Yesterday was a fascinating day to be able to talk to a group here about some of the work you're doing to think about interoception and other cognitive factors which may limit people's ability to continue to exercise. In a sort of strict way of looking at physiology and looking at the way that the cogs might perform, the way that they respond to an exercise challenge, you can do that by performing this cardiopulmonary exercise test. Here's Chris Froome, he's a Tour de France stage winner. He's undergoing a cardiopulmonary exercise test with a very high recorded VO2 max or maximum oxygen uptake. And essentially, for those of you who haven't seen this type of test before, you basically put someone on a bike, they have a mask on which fits very tightly, and it measures the ventilation and the flow of air. Within the flow sensor is a little thing which senses the gas concentrations. And by combining the flow and looking at the gas concentration, you can work out the flow of oxygen in and the flow of carbon dioxide out. I was saying yesterday that there's not many people, maybe fewer in Australia actually than there are in the UK, but certainly less than the Netherlands, who jump on bikes and actually ride bikes very vigorously. And so our modality where we test exercise performance based on a bike-based test that increases in intensity isn't really very realistic in terms of what people do in real life. And yesterday I was emphasising some of the data and the importance of trying to measure these things in a more physiologically appropriate context, for instance when climbing a flight of stairs. Anyway, what happens when you do exercise is that essentially when we test people, we make sure they've done a max, we test they haven't stopped because they've got knee pain or they've got a sore backside on the bike. And then we measure their so-called peak oxygen uptake, which is measured from a mass measurements, the flow and the oxygen concentration. And with that, we're trying to measure it to what we might compare or deem to be an appropriate value, which is taken to 80% or more predicted value for someone's age and height and other characteristics. If it's above 80%, we typically say that people are normal. If it's less than 80%, there's something abnormal going on. And this is usually the branch point which leads to some of the problems about certain respiratory limitation. And so if someone's got an exercise capacity that is reduced by less than 80% of what is predicted for that individual, we then divide them up into one of two groups. You either have a respiratory limitation, based on the fact that you've got your ventilation quite high, I'll show you that on the next slide, and therefore there's a limiting factor with your ventilation, or actually you're cardiovascular limited because your heart rate got close to where it would be predicted to get to. And by and large, that's the sort of Nonny does cardiopulmonary exercise testing interpretation, where people divide people into normal, respiratory, or cardiac limited. When I teach cardiopulmonary exercise testing in the UK, and certainly to trainees, I try to explain to them when they're interpreting the values that come out of these tests, is it cardiovascular or is it respiratory? And it's always hard to explain to people that actually it's completely normal to run out of heart rate when you're exercising hard. So if I put you on the street and you're running down, you have a heart rate monitor on your wrist, it would be expected if you're running incredibly hard, you can get close to your predicted maximum heart rate, which is roughly calculated as 220 minus your age. So you're kind of cardiovascularly limited, but if you remember that your VO2 is actually probably normal, near normal or above 80% predicted, you're not really limited. But if it's low, and you've got close to your heart rate, certainly you are cardiovascular limited. So what about ventilatory limited? Well, we have a similar ability to set ceiling ventilation in exercise, and we typically do that by multiplying the FEV1 by 35 times, and that sets the theoretical so-called indirect MVD. And then you get someone to exercise, and usually they stop with what's called a ventilatory reserve. So there's still quite a lot of capacity left in the system. And you're stopping exercise. And people say that actually there is a big reserve that's left, but of course you have no heart rate reserve because you've got close to where you predicted to get to for your heart rate. Whereas in someone with lung disease, their ventilatory capacity, because their FEV1 might be reduced, the ceiling is much lower. And when they exert themselves, they get closer to that ceiling effect, and they're so-called ventilatory limited. I pay emphasis to this point because this is one of the concepts that people use to say that actually the lung is overbuilt in healthy people. It's overbuilt because of this ventilatory reserve that's there. Now, I don't know of any biological system where something is developed and evolved over time where one system is overbuilt for purpose. It doesn't tend to occur from an evolutionary perspective. And that begs the question of what is going on, and we're just looking at a measure which is simply too crude to decree whether the system is overbuilt or built just right, or actually is there a phenomenon where we do have reserve. In fact, it was an evolutionary thing which made us have more reserve from a pulmonary perspective. If you like these diagrams and you like to think about an easy way to interpret these, I can recommend this excellent book, which is a practical guide to interpretation of cardiopulmonary exercise test, which is available on all good. Yeah, just to emphasize that, sorry. If you purchase one, I get about 1.20%. That's always good. So look, I mean, if we say that's a sort of simplistic way of teaching people or thinking about ventilation and how it works for them, where the ceiling is, then actually maybe there is something a bit more complex that we're missing. And that really is the purpose of this article, to try and delve a little bit deeper and think, what could be the factors that are limiting us from a pulmonary perspective, or can we assess that in more detail? And so listen, I'm not going to try and stand up here and talk at great length about some of these very complex issues. I'm not a pulmonary physiologist in the truest sense, like Jerome and others. Within this article, we discuss, Jerome largely discusses some of these other factors which are relevant in consideration. And firstly, to think about how gas exchange is defended when people perform very vigorous or hard exercise. Pulmonary circulation is working very hard. Cardiac output lifts itself with huge circulatory stress. But of course, as the blood circulates through the pulmonary circulation, it has to pick up oxygen. And there comes a point where transit time effectively is to pick up oxygen. Lots of athletes, highly trained, completely fit, desaturate on exercise and get desaturated to the low 90s. There's nothing wrong with it at all. It's a huge headache in clinical practice because, of course, you see someone who's desaturating in exercise. And they say, like, I'm breathless, what's happening? They've got a completely normal physiological phenomenon to exercise-induced arterial hypoxemia. I have to then put them through VQ scans, shunt study, and other things. I have to make myself satisfied with having got some problem with pulmonary circulation as a cause for their symptomatic presentation. The second issue is about the pulmonary circulation and what happens when you really push huge amounts of cardiac output through a system, whether the pulmonary circulation can dilate or handle the pressures that are placed on it. Whether that has a pressure effect on the right ventricle and how that interacts with the left ventricle to maintain force output and cardiac output, which is so crucial to performance. And that's Andrea Gersh's real big area. And then there's areas, and people think about respiratory muscle performance and fatigue. But as I said, I'm not an expert in those particular areas, although I'm happy to discuss it at the end. And what I want to focus on is airway functions and limiting factor, which is my real contribution to this article. And I want to just tackle that in three ways, really. I want to think a little bit about what happens in smaller airways, or the airways that we're more familiar with in terms of dealing with asthma or exercise-induced bronchial constriction. Secondly, what happens at the level of the larynx, which is a big area of interest for mine. And then thirdly, I'm just going to show you some data that we've recently collected, looking at how the trachea and the main bronchi might be affected by exercise. So we'll take those in order. They did a beautiful job of presenting all this yesterday, so I'm sorry to sort of go over the ground that you showed yesterday, but for a different audience today. And if we just think about pulmonary physiology in terms of what happens when people do breathing tests, and of course you sit in a box and you do breathing in and out, we're able to measure lots of different lung volumes and how much is left in the lung by doing body box measurements. And so you breathe at a tidal volume, you're breathing in and out, and there's obviously the degree of air that's left in the lung at the end of your breath called the residual capacity. When you exercise, there has to be an expansion of tidal volume in order to satisfy the increased amount of ventilation, the increased amount of the working muscle for oxygen, for carbon dioxide clearance. So there's a change where the tidal volume expands and the end expiration level volume has to drop, and the end inspiration level volume has to drop as well as the tidal volume expands outwards. And that has effects, as you can see here from the list, on the way in which the pulmonary mechanics has to respond and the muscles have to respond to that challenge. We take spirometry, which you're familiar with, where someone sits in a chair, they take a deep breath in and then blow out as hard as they can at their peak flow, and they keep on blowing to get the FEV1 and the FVC. You get a maximum inspiratory flow volume envelope, you can see. You get them to take a deep breath in, and you see the inspiratory flow. And you can see in the grey tidal flow in the middle of the screen, when you're sat there at rest, nowhere near maximum inspiratory flow volume envelope. But then when you exercise, you start to need to expand out the tidal volume, and it expands in a way within that loop. What actually happens in healthy people as they start to exercise is that there is a repositioning of the way that the tidal volume sits within the pressure volume flow curves, so that actually it becomes more advantageous for the whole system as it adapts to the pressures that are placed on it during exercise. What that means is that essentially the tidal volume flow loop moves across, as you can see, towards your right-hand side of the screen. It positions the pressure volume curve in a better place, so that actually, for every movement of the diaphragm, the traffic which is going from the brain down to the diaphragm, it's moving more volume because it's in a much more efficient way. Position. And so when I explain that to medical students, other trainees, what I say is that essentially it's like going to pick up buckets of water. But if you're going down to pick up a bucket of water, you wouldn't pick it up with an outstretched arm, you pick it up with a bent arm so you can actually get good leverage on it. And the same sort of thing is happening in the way that the diaphragm has positioned itself when you're exercising command. Now, of course, it's a different scenario if you have obstructed lung disease, where you can see that there's a reduced flow value, so there's an obstructed position of the flow volume loop. I think quite often we forget to actually look at the ratios and to look at the position or the shape of the flow volume loop, which has so much information in it in terms of how people are able to exercise. But essentially, the individual there with the dark red circle with the tidal volume flow is okay at rest. When they start to exercise, they have to increase their tidal volume. There's no space to expand. They hit the maximum expiratory flow volume envelope, and they can't continue to increase their tidal volume to satisfy the working muscle. Only one way that can change, and that's by moving that curve now in the opposite direction to what happens in health. As you move in an opposite direction, you get a decrease in inspiration capacity, and you get a positioning on that pressure flow volume loop, which is far less advantageous. So you're having to do much more work and send more neural traffic from the brain down to the diaphragm in order to affect a certain volume change. And now you really do have a situation that some of the buckets can open an outstretched arm, which is incredibly fatiguing, and you understand why people perceive dyspnea in that scenario, because there is so much more neural traffic going down to the diaphragm for a given amount of work. Let's just return to sport. And so there becomes the question of whether, if you're very, very highly trained, you've got fantastic muscles, you've got a fantastic cardiovascular system, can you push your ventilation to a space where you're increasing your tidal volume so much, you start to encroach upon what might be a normal tidal volume loop called a maximum expiratory flow volume loop. Indeed, that's what's been shown in Kenyan endurance trials. They can push themselves to the point where they become expiratory flow limited, even though they don't have airflow obstruction. So will now push down to their respiratory gear. And that's even more prevalent, of course, in the masters athletes or aged athletes, where you will naturally expect to get some scalding of the flow volume as you get a bit older. It's also potentially very relevant in people who have so-called dysynapsis of the lung function, where the FEV1 hasn't quite kept up with the FVC, so you get a scalding position or a scooped out flow volume loop. And we see that in certain groups of athletes, particularly, for instance, in rowers. The consequence of that is that when you start to get expiratory flow limitation, you're unable to continue to clear and achieve the ventilation you need, and therefore you start to retain gas, you're not able to clear it properly, and then you can see consequences of your gas exchange, where you can start to see desaturation, and maybe partially contributing to the exercise-induced arterial hypoxemia that we mentioned earlier on. The other thing which I think is still very overlooked, and certainly overlooked in the field, for instance, of asthma or understanding what happens when people try to do things, is that these systems aren't built to just exist on their own. There is a complex interplay between the peripheral musculature and the respiratory musculature. So again, another nice series of studies done by Lee Romer and Jerome Dempsey showed that if you look at what happens when the ventilatory or the respiratory musculature is placed under significant workload or pressure, a bit like having the arms out of the buckets on it, there is a system of neural traffic. There's this remarkable crosstalk between the skeletal muscles and the respiratory muscles. So when the respiratory muscles are placed under pressure, the arms are stretched outwards. If you measure sympathetic activity in the muscles, the peripheral muscles, there is a signal which is almost trying to sort of down-regulate or turn off the peripheral muscles. We don't know whether that happens in asthma, but it may be an interesting study to see what happens to the peripheral muscles. And of course, it's a signal to try to slow the system down and give you the peripheral fatigue related to the breathlessness, which is often still not considered. Some of the very nice studies that have looked at this have addressed this by trying to offload the work of breathing by putting people onto ventilators when they're exercising, so the work of breathing really drops away. And you see contemporaneous changes in the sympathetic and peripheral musculature. Not easy studies to do, but very nice and have obviously a lot to understand. So that's what happens in the context of a chronic airflow obstruction. What happens in the context of things like exercise-induced bronchoconstriction, a phenomenon where the airways close down in response to exercise. It's most commonly seen, for instance, in people who have a history of asthma and then they go out running in a cold, dry air in the morning time, and they simply feel a chest tightness and feel like they can't get enough air in. We typically measure this condition in the laboratory by looking at lung function changes in the post-exercise phase. So people do a 6-minute exercise challenge with a dry gas inhalate, and then we measure their spirometry before the test, and then we measure it for 3 or 4 or 5 minutes intervals, 20 minutes after the exercise test. And we're looking for a significant reduction in the FEV1 of at least 10% fall. So it's curious, isn't it, that you stop exercise and your FEV1 is pretty much the same as it was, and then in the sort of 20 minutes after you stopped exercise, you see the biggest decrements in lung function as measured by FEV1. You can see here how these 2 actors tend to have for a susceptible individual. And so we know that exercise-induced asthma, exercise-induced bronchoconstriction, airways hyperresponsiveness are incredibly prevalent in athletes. Yesterday I shared these data showing this systematic review that over the last 40 years, I think we've sort of consistently demonstrated multiple different studies that about 1 in 4 to 1 in 5 endurance athletes have some form of that sort of asthma-related type issue, and particularly prevalent in aqua and winter sport athletes. And the question that is always asked of me is, well, how does that affect performance? Surely it must make a big impact on those athletes' ability to perform. And it's interesting that asthmatic athletes typically outperform their non-asthmatic contemporaries, and there's a disproportionate representation on the medal table of asthmatic athletes versus non-asthmatic athletes. Some people think that's to do with the medicines that they're taking. Other people think it's because they have a training advantage, because they've had to work that much harder. It may actually just be something to do with the fact that asthma doesn't really make a huge amount of difference in performance. That's a pretty controversial thing to say, because intuitively, physiologically, if your airways are narrowing in the context of vigorous exercise, it must impair performance. A few years ago, we did a systematic review to try and understand whether there was actually any data in that area to try and speak to that question specifically. There's very little studies, very few studies. This study in the States actually acted in a bronchoconstricted model, and in the bronchoconstricted state, got them to then perform an exercise challenge, and then looked at markers of ventilatory efficiency, ventilatory work, and actual overall performance. And rather sadly, there doesn't appear to be a lot of difference in the bronchoconstricted state. So whilst there is a sort of obviously an intuitive feeling that people would have a massive impact on their sporting performance by being in a state of PIP, there isn't necessarily the science that actually backs up that statement. And that's maybe because we haven't got the right sorts of studies, but certainly isn't there or available at the time. The other thing to say about exercise-induced asthma is that we screen athletic squads using this test called ISEH, it's a dry gas inhalate test, indirect form of bronchoprovocation. So someone breathes in a dry gas, measure their lung function before and afterwards. They're looking for bronchoconstriction. It's often taken as a sort of gold standard surrogate measure of exercise-induced bronchoconstriction. And a few years ago, we undertook a study where we took a squad of athletes who were completely asymptomatic. They had no problems at all. We put them through the ISEH test. They never had any problems with their breathing. And we measured what the average fall in their lung function was after this exposure. And what we found was that elite athletes were more likely to fall than non-elite athletes to a greater degree. That the average fall was about 8% of their lung function. And you can see the standard deviations suggest that a 10% fall is actually well within the normal range for many of these athletes. So what is the point I'm trying to make with this really? Well, essentially, the state of bronchoconstriction occurs in the context of exercise in many athletic individuals may not be a pathological or problematic scenario to deal with. A similar sort of thing you might draw an analogy with is what happens to the left ventricular muscle during exercise. So if you take someone off the street and you don't know how much sport they've done, and you do an echocardiogram, you see thickness in the left ventricular wall, and of course straight away your mind will go towards whether you've got a cardiomyopathy or significant cardiac disease. Whereas if you know they've been training for 30 or 40 hours a week, and they're an endurance athlete, then you have to view that with a different mindset. And I think there's some science really to be done to try and understand what it is in athletic individuals that is normative, or the normative airway response to the challenge test. And in some ways, there may be an adaptive process which is trying in some way to protect more distal blood by causing some degree of bronchoconstriction, which isn't relevant to performance. but there's a physiological normality for highly trained individuals. I put those out as concepts. I'm very happy to be shot down those later online or whatever, but I mean, they're just different ways about thinking about the sort of problem that we just take as a dogma and as a given, the narrowing that we see must be a consequence to the athletes that we deal with. So our conclusion from the paper looking a few years ago at what is data evidence for the impact of exercise-induced asthma or exercise-induced bronchial constriction performance was that there isn't a lot of data. And actually, perhaps we should be looking at other metrics of how this is affecting people. And maybe, again, thinking about how the brain sits within this model, because it might be that we don't see physiological consequences there in what work, but we do see a decrement in performance because people sense that there's a problem because they feel the tightness or the chest restriction or other feelings, then leading them to avoid exercise or to reduce the intensity of that exercise at that point. So let me just turn now to a different section of the airway, particularly to the larynx. And I showed this video to some of you yesterday of a young athlete, if you get a sound on that. Running in at the end of a vigorous exercise bout, struggling, wheezing, breathlessness, and clearly very distressed with that. And actually, that noise is arising from turbulence in the upper airway. The upper airway closing in a condition called exercise-induced laryngeal obstruction, sometimes known as exercise BCD. If we turn our attention back to the flow volume movement, what is occurring on this occasion is, of course, nothing to do with the expiratory flow volume movement, which can still look completely normal, but an attenuation in inspiratory flow, which is measured and typically assessed at the sort of midpoint of the flow. When I sit down with athletes and I explain or talk about this condition, I try to explain in terms of the laws of physics. Essentially, what is happening is that if you have a tube and you're changing the pressure gradient through that tube, and you're slowing the flow of a substance, liquid or air through that tube, then it will have consequences for all the pressures around that tube, which then suck the side walls inwards. So a more simple way of explaining that to people is to say, well, it's a bit like having a milkshake with a thick paper straw. If you suck on it too hard, sometimes the straw collapses in. Of course, if you suck it in a different way, you move the fluid through the straw, and the straw stays open. And that was the basis of what we teach in terms of the breathing techniques to try and keep that straw open. This is what we do with the tests when we're looking for this. I'll show you this video, which shows the structures just above the glottic canal, causing the irritation. Exercise is You done?
Yeah.
So you can see it going in on the top there. Talk about the and it's been interesting to me to understand what it is about the larynx closing, which might have a consequence for breathlessness. So trying to think about other ways of understanding. And of course, if I go back to that model of the buckets and holding the bucket out straight, what I really wanted to understand a few years ago when Emma Wolf's did in a study was the larynx closes, does it have a consequence for the way in which we're positioning the arm around the bucket situation, the diaphragm? Is it changing the mechanics of breathing? Is it having a consequence in terms of the work of breathing? So this study we performed where we floated the catheter in down into the GI tract in order to look at pressures and transforming pressures, and then a catheter down across the diaphragm, which measures the diaphragmatic EMG. And much like if you look at EMG of the muscles, you're interested to see how hard a muscle is working by the EMG traffic. We do the same across the diaphragm, being done COPD and institutional lung disease, to understand when someone is exercising, how much neural traffic is going towards the diaphragm, what EMG system is going down towards the diaphragm, what happens when you work that system. Dennis O'Donnell has done lots of very nice studies looking at this to see if you can use the same principles really, essentially to look and see what happens in the consequence of EI alone. And what we found was that, yes, actually, during normal exercise in healthy control people, you can see an increase in the neural traffic towards the diaphragm. As you're working harder, the diaphragm needs more EMG signals sent to it to keep it working. But as the larynx closes, there is a divergence when the work of breathing increases and the neural traffic increases as well. there's lots of work to be done in looking at neural EMG drive and looking at drive towards the diaphragm, because it's a signal that tells us something about how well that muscle in the breathing system is working. That was great with the whole body session. In a more extreme example, this is an individual who had a tracheostomy from following a back car crash, and they were left with a permanent narrowing of the larynx and glottic inlet. And you can see the hugely attenuated respiratory flow on their spirometry. And with this individual, what we did when we exercised them was they were quite keen to return to playing competitive tennis. So when they did a cardiopulmonary exercise test, the player actually said to me, I'm making a lot of noise when I'm playing tennis, but more important to me is that between a few series of exercises,
Sorry.
I start to fall asleep. So if you're playing tennis, and the more you play and the harder you play, the more sleepy you got. It was a bit like me actually last night with the jet. What we did is we did this exercise test, and what we found was that the harder this individual worked, the louder the breathing became, the harder the work became. But if you just focus on the blue line there, you can see the end-tidal carbon dioxide value, and it was steadily rising and hit 11 kPa. And so essentially it became more of a solid of CO2 issues, not being able to clear the CO2 out of the way. And he had an operation of his larynx, and in fact, I've got post-surgery CPAP data here. The CO2 is much lower, more about 5 or 6. Just for the final couple of minutes, just to turn now to the sort of middle section of the airway, or the large airways of the bronchi. There's an evolving interest, really, I think, in terms of people trying to understand what happens with this area, which is historically been just thought to be a sort of passive conduit for air. But now people try to understand what is actually happening when you drive air over it during exercise. Certainly with some studies suggesting in military personnel that the unexplained breathlessness that these individuals had could be explained by a phenomenon where the airways are collapsing in a form of tracheobronchulation or excessive dynamic airway collapse. You can see that here on the bronchoscopic images where the tracheal wall comes in, or in the CT images where you can see this sort of bowing in of the airway. So we've undertaken this study very recently, which no one really wanted to volunteer for, I think, yesterday, but sharing this video, where essentially we perform exercise bronchoscopy. So here's a healthy volunteer with a bronchoscope, which is obviously going in through the nose and then up sort of midway down through the trachea. I'll show you a video of someone who was actually my registrar at the time having this done for the first time in the UK. Consent. So he has a bronchoscope inserted into the sort of trachea, and it sits on a specialist headgear, much like the same sort of approach that we use for laryngoscopy. There's a bit of search on there for fun. And you go to the trachea, we go on a treadmill, and you'll see him running. Of course, there's no sedation on board. Then we recently finished this work where we were just trying to understand, what happens to the trachea, bearing in mind the military studies and people talking about, like, look at this as a kind of entity. Can we understand what happens in the normative state to start with? So this is the first study that we looked at this, and what we did is we asked these 25 normal BMI volunteers to come along, have an MRI, so we could understand the way we would look at imaging dynamic collapse, and then a normal bronchoscopy, lying flat, and getting people to do forced inspiratory maneuvers. And then what happens when they're exercising to voluntary exhaustion? Say voluntary resistance. And what we found was that if you have a cutoff value that most people do to say that a collapse of more than 50% is an abnormal result, on the MRI studies, 64% of these normal people, normal BMI, no symptoms, healthy control, normal lung function, had evidence of excessive dynamic airway collapse on classical criteria. And that's not a particularly novel finding. People have shown that in medical students before in CT studies. Cautioning the way you use that as a diagnostic cutoff when you see patients. And then in the supine forced expiration, still 1 in 4 of them seem to have some degree of collapse. Similar sorts of figures in the context of semi-recumbent position. The peak exercise, normal collapse. I think it's been helpful, I think, to start to understand this space because it helps us to understand how the modalities that we test and diagnose people may relate to your everyday activity. Because the obvious question now is to look at this in patients with clinical evidence of TB and ED. What happens to them in real life? Because I spend an awful lot of time using CPAP devices that are portable to help these people get around and exercise. And then nothing happening here at all during exercise. So, in conclusion, obviously, it's of great interest to think about whether the respiratory system could be further optimized to help people perform not only on a day-to-day basis in terms of the factors, but also at the elite level, its sports performance. Lots of different factors to consider. I really focus on airway function, which is my area of I've spent time doing some research. The conclusion from our overall review article is that actually the respiratory system probably plays a relatively minor role in terms of their elite professional performance. And therefore, you're probably better off going and buying yourself a set of nice shoes than you're spending hours in a lab with a prostitute system down you or using a powering device. But every little helps. My final slide really is to say that, as we spent yesterday talking about the role of the brain in terms of thinking about the interplay with dyspnea, and I like to think that if we were looking at these vascular blocks and redesign them from new versions of that textbook, the vascular textbook, it would be nice to think about more about the airways, the different segments of the airways, and how they contribute to that final role. But of course, also at the top of the tree, the coral, literally at the top of the tree, and how that interplays with the other system. Stop there. Thank you very much.
Thank you, James. So I'd like to open the floor both in person and online to any questions that we might have. I might start with a question that we have online. So that question was going back to your data around people with asthma not being limited by the exercise-induced bronchial constriction. So the question was what medications, if any, were the people with asthma on when they did those assessments? And do you think, more about, does that have a role in their response? And I also wondered, maybe along with that, whether people or athletes might seek a diagnosis of asthma for misperceptions around, SABA, enhanced performance.
Yeah, so two questions we get asked a lot, really. And for that study, as I understand it, people weren't on any treatment because the aim was to actually deliberately bronchoconstrict. So there's a washout period that then enabled them to actually develop bronchoconstriction. Some of them were reduced down to 20 or 30%. And it's always remarkable to me when I do that EVH test, sometimes I stand next to athletes who drop by 60 or 70% of their lung function. They feel completely fine standing, they go, this is wrong. They're sensitive to all. So that's interesting. I just wonder if when I think about from a personal anecdote, I ride as an asthmatic cyclist, and I know that if I go off very hard, the router really hard from the gun, he's always struggling. There's a few minutes where he's really bad, and then after about 8 or 9 minutes, he starts to get his breath back, and then he comes back, and then the rest of the night's pretty miserable for me. But there's something I think we're missing in terms of the measurements that we actually have to take, rather than being something that is inconsequential, I think. Second question about taking medicines to enhance performance. Again, it's a bit of an evolving space. Most of the historical literature suggests that when taking the physiological doses, asthma medications do not enhance performance either in an asthmatic or in a healthy control. There is some more recent data that from Copenhagen suggests that you take super physiological doses, you can see definite increments in power performance. We're talking massive doses and how they tolerate some of the doses we give. The 20 or 30 times more therapeutic doses of something tomorrow, but 2 hours.
Do we have any other questions in the room?
Maybe just on that, because I just thought it was interesting in the non-asthma athletes, how they dropped like the 10%, I think you showed. And the people with asthma tend to do better on the podium. So they're both, having some drop, and someone is treated and someone's not. You kind of then have to wonder, given what you've just said, the perception of the effect of those SABAs, I suppose.
Yeah, I'm sure there are effects on people. And one of the toughest things is, say, a few years ago, in order to use a beta-2 agonist, you had to have a therapeutic use exemption, so you had to have proof that you had evidence of an asthma process before you were permitted to use a beta-2 agonist. And that's changed now over the last sort of 7 or 8 years. One of the toughest conversations was trying to explain to athletes who always had a beta-2 agonist they hadn't met the criteria for a therapeutic use exemption, and therefore they couldn't have the beta-2 agonists. Yeah. And there's a huge panic that was an established treatment they'd used since they were younger, and you take that away. Many of those athletes do fine, but they still compete very well, and you say.
Yeah, I wonder what the impact of respiratory training would be, the impact that have their SALVA, on the athletes that have their SALVA removed. And they felt that respiratory training might safety.
Yeah.
Peter?
Yeah, thanks, James. Just could you take us through your cycling with your friend and how that relates to what we've presented about exercise, which is bronchoconstriction, in the symptoms and bronchospasm come on at the end, 20 minutes after exercise.
Yeah.
Whereas your friend is getting symptoms during exercise.
Yeah.
And then they go away. So what happens? Why doesn't that relate to what we're taught?
Yeah, I don't know. I mean, I spent a lot of time chatting to athletes who have got confirmed exercise-induced asthma. And I always hear a similar story. It's hard to get going, it's hard to get breath to start with, it's tightness to start with. And then it seems to sort of get a bit better. And so this physiological measurement in an exercise cessation state is what is happening early on. I wonder whether actually there is a degree of ventilation heterogeneity, as you've shown as a treatable trait, I think, in general asthmatics, where the pockets are not opening up, and that is increasing neural drive early in an exercise bout, and that's the consequence you're feeling. So it needs far more subtle physiological assessment than measuring FEV1. I mean, it's just such a crude tool, so it would be very nice to be able to look at neural drive early in about EIB and see what happens. I think it'll be something around that that causes the
Is your question related to that? Yeah, okay.
So there is some evidence about a refractory period of EIB that suggests that the early onset of the issue will actually resolve with continued exercise. So there's quite a few EIB athletes that will actually present with an initial bronchoconstriction following the subsequent bout of exercise. It doesn't exist. And if you're doing a lengthy endurance exercise, if it's steady state in the lab, you don't see that because the exercise never gets a chance to refract. But if you're doing a whole real world exercise, you have fluctuations in your exercise intensity. So it's quite often that the initial bout will have a refractory period where it resolves through the exercise. And there's limited evidence in there. There's no experimental evidence from the lab, but I think you're very right that is going to need to be done.
We have a question online about ILO, and if an athlete gets a diagnosis or ILO, is that career ending, or what's the pathway forward for that? And how effective is the therapy?
The therapy is very effective. So our understanding of the longitudinal development or the outcome from ILO is still pretty primitive and limited. Generally speaking, people get referred initially for a therapy-based approach, so physiotherapy or speech and language therapy in some parts of the world. And in my hands or the referrals that I make, I think about 60 to 70% of people make a big improvement with that type of therapy. And there's a small proportion of people who don't respond to that. For some forms of ILO, will be appropriate for a surgical procedure, a laser operation, which can then stop structures falling in. The difference with the longitudinal data, so to say, what is the outcome, is that quite a proportion of people stop doing sport. This has its peak in science at about the age of 15 to 16. If you follow these individuals, there's some kind of labor studies that they're doing into their 20s. So people stop sport because they don't want to do sport anymore, so they don't get this problem because it's an exercise-related phenomenon. Some people genuinely have given up sport because their symptoms are still so bad that they've actually done other things. And then there's some people who obviously feel a lot better, and it's just, there isn't really the evidence that helps us inform discussion.
I have a question kind of on that. For aspiring athletes who don't necessarily have the resources that elite athletes do, there is a sense of hopelessness when you do start getting these symptoms and you don't really know where to go. What advice would you have for them as to where to go to help your respiratory performance and improve that?
No, that's a great question. I mean, yesterday I shared a video that suggested that if you're wheezy and your breath is struggling, you can often go to see your local doctor and say, oh, it's asthma, and they give you an inhaler, and it doesn't make any difference. If you take a video of yourself when you're wheezy and you say, look at this, this is the type of wheeze I get, you might still get the same response, I have to say. You might also be able to open a discussion which says, look, there's actually some other process which is causing this, and I haven't really responded to the inhalers. And I've gone full circle from 10 years ago, trying to inform guidelines, trying to help do educational events, trying to teach and spread the love and the message of IO, to do the other way now, which is basically get a message out to the athletes, to people out there, and then get them to go to the doctors and say, I think I might have IO. Because I've given up the other way, because it's still, most people who come to me have been waiting for 2 or 3 years to get a diagnosis. And then we can be better at forcing resources into TikTok and Snap or something. But I mean, Snap. That's the target audience. They're 14 to 15-year-olds, and their kids look at TikTok and stuff. So we need a TikTok ILO star.
That's it. Are there any kind of patient-targeted resources that they can go to that are on the internet, and they just have to find them in order to help themselves a little bit with that as well?
The only one I know is there's one in the Blue Journal, the American Journal of Respiratory and Critical Care, and it's not published very much now, but it's behind a paywall. So, I mean, I don't know whether patients can access it, but I can't get anything out of that journal. I have to go through a Russian site to access it. But and it's still recording it.
Should we put one on the Centre of Treatable Trait website?
Yeah.
Develop one together.
Yeah, for sure.
Yeah.
We also have a question online from Chris Grange, and he asks, as athletes age, does the physiological reduction in lung function impact performance, even if it doesn't in youth? So I guess, the impact of aging.
Yeah, and so we were talking earlier on about that expiratory flow limitation problem. Obviously, as we age, there is a sort of more natural scalloping out of the flow volume. So people start to look more and more obstructed. In fact, it's the sort of criticism for why if you take a FEV1 over a VC ratio of 0.7, that's kind of fine up until the age of about 43. And then after that, you're still quite normal, but you look obstructed if you use that cut off. And so I think there's a lot more we should be doing and thinking about in terms of flow volume loop shape. As you get older, the shape of that flow volume loop is far more likely to impede tidal volume expansion and have effects on pressure and volume mechanics, I think. And there are some nice papers recently that show that artificial intelligence systems are able to detect expiratory flow limitation from the different shapes of the flow volume loop without necessarily just using abstract measures of FEV1 or FEV1 VC ratio. And looking at the shape of that curve gives a lot more insight, I think, in terms of why people feel breathless from airways or so.
On a similar theme, we have a question around managing hyperinflation for people who have COPD. So do you have any tips if someone's running with COPD and experiencing dynamic hyperinflation? What can they do?
I mean, so there's a couple of things really. I mean, ventilation is heavily linked to the amount of muscle bulk you're using. So as we were talking about eccentric and other different types of modes of exercising the muscle without putting ventilatory load in the system. Another way to do it is single leg cycling. So you're using one particular leg and then you change it to the other leg. It's less likely to put your ventilatory system under into that situation where you're increasing the load. The other thing which can be useful, as has been published in the States, is to use sort of sinusoidal loading patterns, essentially like high intensity training. So you end up driving the system, working quite hard, challenging the cardiovascular and the muscular system, then backing things off before people get into that trapped situation. So you're loading them in that sinusoidal vein. I use that quite a lot for people after used to that.
What about the role of breathing exercises?
Yeah, so pursed lip exhalation is obviously a helpful strategy. again, I was showing yesterday, we did some work where we looked at the camera in the larynx in people who are dynamically hyperinflated. It seems that the larynx acts to also try and narrow down an expiratory form of what you might call expiratory BCD, but it seems to be trying to actually provide some water pressure into the system. And so you may be able to exploit that more. In fact, I think a Japanese study did that recently with a breathing muscle strength technique to try and improve laryngeal movement, to try and provide water to offset that inflation.
Any questions from the room?
Could you comment on the exercise environment and what effect that might have? A lot of us medics react to triggers. That's one aspect I was thinking of. The other is this concept of green exercising outdoors versus indoors.
Yeah, I think that's amazingly relevant and important, especially in the climate we face, the challenges we have, especially pollution and other things. It's interesting that we were saying yesterday about swimming. Back in the day, people were encouraged to take up swimming. You were asthmatic because of the warm and moist environment. And yet, at the same time, if you've got people who are training in an environment with lots of chlorine, the airways become sensitized and irritated by that. Just as an aside, I've always amazed when in the UK, when you go to swimming baths, you have to go past a little shower and a booth that you have to walk through before you get into the pool. And everyone sort of walks down the side and sort of gets past without going into the cold showers. But actually, that's the thing that's causing the exercise-induced asthma in the athletes who are going up and down in the outside leg. Because what you're doing is you're getting down into the pool, so you're now washing off the sweat and body odor and other things. And that's what's reacting with the chlorine to make the chlorine ions, which sits above the layer of the water, which then the athletes who are doing many hours of training and inhaling, and then causing the asthma. I don't know about allergens and other things, but I think, the argument I get from pollution experts like that is it's better still to exercise in even a polluted environment than it is to not exercise because the overall health benefits still outweigh the effects of pollution to our lungs.
Our webinar is just about to end for our online audience, so we can continue conversation in the room, but I would like to thank all our online participants for joining us, and thanks James for such a great presentation and for answering all of our questions that we could ask for hours, I'm sure. But I'd just like to say, thanks to the online members, and we can continue in person. Sorry.